In this session, we'll study and talk about the ancillary ocular testing, referrals, and follow-up. Now, while there are a number of ancillary tests which can be done on patients with retinal obstructions, many may seem to be superfluous, but in fact may help with the diagnosis or help in planning your follow-up. Some of these ancillary ocular testings can include fluorescein angiography, optical coherent tomography, ERG, and occasionally ancillary grid testing or visual field testing. The first test we'll talk about is fluorescein angiography. If you do see a patient with a full-blown artery occlusion with a classic macular edema and a cherry red spot, you don't need a fluorescein angiogram to make the diagnosis. However, obtaining one at 1 week is a very valuable test in helping predict rubeosis. This is a 70-year-old gentleman who lost vision about a week prior to his evaluation. Note the intense macular edema and the cherry red spot. There are also flame-shaped hemorrhages around the nerve head. A week after we saw the patient, we were able to get him to one of our offices that had the capability of angiography. And you can see the acute hemorrhages around the nerve have absorbed, but the cherry red spot indeed is quite prominent. The fluorescein angiogram shows that the retinal arterial system is not filling even in the late phase of the angiogram. You can see that some of the vessels will fill to the temporal macula, but the rest of the retinal arterial system is unfilled. Very soon afterward, he developed florid iris neovascularization. The rate of iris neovascularization can be as high as 20%, and it occurs earlier than that found in central retinal vein occlusions. J. Duker published an article in Ophthalmology in 1998, and in that study, he found that if the central artery was still closed 1 week after the acute blockage, the risk of subsequent rubeosis was 67%, compared to the 25% rate if the artery was open. Fluorescein angiograms can also be helpful in patients who do not fit into the routine category of the 60, 70-year-old hypertensive male. This is a 40-year-old female who presented with good central vision, but she noticed some missing spots in her vision in the mid-periphery. Not only can you see the cottonwool spot superiorly, but there's also an occluded artery just superior to that. On her fluorescein angiography, she showed more involvement of different arterioles than just the one associated with the cottonwool spot. You can see both along the infratemporal arcade and 2 different arterioles in the superior arcade that she has typical ellipsoid staining of the arterioles. This ellipsoid staining is pathognomonic of Susak disease. Here is another younger patient with an artery occlusion. This is a patient of Dr. Stephen Kim. She's a 52-year-old who had noticed sudden vision loss 4 days previously. Her vision was found to be 200. You can see the intense retinal whitening that is in the area being fed by the infratemporal macular arteriole. You can also see some subtle, deep, whitish lesions scattered in the posterior pole. She's found to have high toxo and Bartonella titers. The toxo titer decreased fairly rapidly, but the Bartonella remained high, so she had a diagnosis of Bartonella retinitis that occluded the infratemporal macular arteriole. And here's her angiogram. And there are a number of notable findings. First, you can see the infratemporal macular arteriole is not filling, and there's a large area of hypofluorescence in that area. Now that's probably a combination of blockage from the intense retinal edema and also non-filling of the capillary in that area. On the late phase, you can see that there is a hyperfluorescence in the area of the blockage and also from the nerve, showing there is a little bit of neuroretinitis as well as the arteritis. Eventually, her vision did return to the 20/40 level. An OCT is helpful not only just in documenting the amount of edema and where it is, but it can also help in patients who have just very subtle clinical presentations. It is also helpful in patients who have PAM, but that is a topic for another study session, which we have online. This is an 81-year-old patient who lost vision several days prior to presentation, but the vision began to return. At the time we saw her, the vision was recorded at about 2100. You can see the macula just has some very patchy areas of retinal whitening. There's not a classic cherry red spot. The arterioles are narrowed, but not too much considering this patient is 81 years old. The fluorescein angiogram shows fairly normal filling, both in timing and inclusivity of all of the retinal arterioles. The upper left hand is the early phase, and even though the quality is not as good as you'd like, you can see that the arteries are filled. In the upper right is the mid phase. They're symmetrically filled, and in the bottom two are the mid and late phase angiograms. There may be some slight hyperfluorescence of the nerve and maybe a little bit of hyperfluorescence around the fovea in the bottom right, but there's really no big sign of occlusion, capillary loss, or great signs of leakage on this particular angiogram. This patient's OCT was helpful in that you can see the hyperreflectivity in the inner nuclear layer typical of arterial occlusions. It is more intense just temporal to the fovea and patchy nasally. And here's another example of how OCTs can be helpful. This was a 51-year-old male who lost vision in the right eye for about 5 minutes, 4 months previously. He had a second episode 4 days prior to presenting to the emergency department, and again 9 hours before these photographs were taken. His vision was found to be 2400. There are not many clinical findings. I think you'd be hard-pressed to look at that, except for one little area of decreased pigmentation temporal to the fovea, but you'd be hard-pressed to say, oh, I see an occlusion, I see a cherry red spot, I see macular edema. That, I think, would be stretching your findings. The lab work had a normal CTA of the head and neck. The CBC was normal. The CRP was just slightly elevated at 6. The side rate was 10. And here's his fluorescein angiogram. It shows very symmetrical filling of the arterioles and total filling in the late phase. The only thing you can see are just some very subtle spots of hyperfluorescence scattered about the macula. Now you could say, well, gosh, could this be an occult net? Yes, although he doesn't have any signs of macular degeneration, and he's a bit young for that, but the angiogram itself is not diagnostic. This patient's OCT was very valuable in coming up with the correct diagnosis. You can see both on the horizontal and vertical cuts that the inner nuclear layers are very hyperreflective, and this is a sign of arterial occlusion. So while the clinical was not very obvious, and also even on the angiogram was not very obvious, here the OCT does come into play and helps you with the management of the patient. The visual fields may help document the loss of vision, and as with tumors and other things, the more dense it is, the least likely it is to come back, and the less dense and more feathery borders, the more likelihood there may be some return of vision. I really doubt that anybody would be getting ERGs on acute occlusions, but when it was being studied, as you would expect, the B wave was diminished, but the A wave was normal. So let's finish this session by talking about the systemic associations with retinal artery occlusions and what to do about the medical follow-up. A number of articles have found that up to 1/3 of the patients with acute retinal artery occlusions have suffered previous asymptomatic strokes. 20% have been found to have critical cardiac disease, and in the few weeks following an acute artery occlusion, there's a 2% to 5% risk of developing a stroke. So let's break down some of the cardiac findings. 50% of patients may have structural cardiac pathology. 20% in one article were found to be critical. 10% were severe enough to require anticoagulation or surgery on an emergency basis. Echocardiographic findings showed that 27% of the time were found on transthoracic, but 59% on transesophageal echocardiography. Now, artery occlusions in younger folks do need to be looked at differently. Obviously, we've already shown you how angiography can help, but also a fair amount of people will have abnormal transthoracic echoes, and a larger percent will need anticoagulation due to a variety of hematological problems. If the patient is younger than 45, they're 3 times more likely to need cardiac treatment. The survival time of someone with an acute central retinal artery occlusion is 5.5 years compared to the average of 15.5. The reduced life expectancy is secondary to cardiac disease. Now, it's important to get carotid testing when they come in because of that 2 to 5% risk of a stroke in just the next several weeks. But these are not fatal. But obviously, the patient needs to have that worked at, but also a really intensive cardiac follow-up to try to change that survival time. So, what's the real-life medical follow-up statistics? In a recent article, Yusuf et al. In Ophthalmology reviewed 2,800 emergency department records from 2006 to 2014 of patients who had retinal artery occlusions. 20% had brain testing, 7% had carotid imaging, 24% had cardiac testing, and only 4% had all 3. So this is where you'll have to be the captain of the ship and tell the people in the emergency department what you need and what the patient needs. So, in summary, acute artery occlusions need to be sent to the emergency department. Tell the ED what you want. You may not be referring to a university hospital that has a stroke team available, so you need to tell them you want a minimum of a CTA of the head and neck. You need a cardiac echo. You need labs to rule out giant cell arteritis, and they need a follow-up with cardiology because that is the highest risk factor for mortality. But they really do need to look at the carotids also because there's an increased risk of a stroke in the next week or two. If the retinal artery occlusion is greater than a week, you do not need to send to the emergency department. But you do need to contact the primary care doctor, relate the needs for the tests, or you may just want to order them yourself, but I'd probably go back to the primary care doctor. Many of these patients are elderly. They already have a cardiologist. I would call the cardiologist and say, hey, this person has cardiovascular disease being manifested as an artery occlusion, and could they order it? And I think they will help you out on that. And then I think angiograms are helpful, but do them a week or 2 after the occlusion because that will help predict rubeosis. And you do need to follow them just as you do for these central vein occlusions because they do have between a 20% and a 60% risk of rubeosis within a month, depending on the finding on the fluorescein angiography.